going to discuss about some very interesting journal articles which are relevant not only from the current scenario but also from a futuristic. Looking into these journals and these other areas is basically to look at how they can change our clinical practice. So whenever we are looking at a paper, we have to decide about whether this paper demands a change in our clinical practice or not. So I'll request all the speakers to discuss about the applicability of that to our as well as other similar resource scenarios, whether this paper will make a change in our perspective or not. So first of all, we have to decide whether this paper is really valid or not. So what are the difference between validity and reliability, Dr. Alapan?
Reliability is how much we can rely on the based on the data that is present in the paper, and validity is how much the clinical implication in that paper could change in certain clinical.
What is the difference between precision and accuracy? So which means if it is, if you rely, it may or may not be valid, but still you can rely on the paper.
No, sir, the other way around. It is valid. We can rely on that.
Yes.
But the reliability depends on the whether the paper is valid or not.
So what is the reliability then? Reliability is basically repeatability. If you do the same measurement 10 times, 9 times you get the same answer, it may be a wrong answer. That will be repeatability, reliability, or precision. So when you say validity, it is the truth that you're looking at the truth. So accuracy and validity will basically mean that you're looking at the truth. Reliability just means that this person comes 1 hour late every time he comes, he is very reliable, but he is not valid. So validity is more important than just reliability. Every time you are saying this is a horse, when you are actually seeing an elephant, you are reliable, but you are not valid from that perspective. So whether a journal is valid or not. The second major thing to look at,
reproducibility is same as the reliability.
Repeatability, reproducibility, all that are, these are the same terms as precision. These are all factors of reliability. Generalizability is very important, whether some research which has been there is applicable to everybody. So if somebody does a particular research in some particular ethnic group of different age group, it may not be relevant to our children or children across the globe. So this generalizability also becomes important. Of course, whether it provides us with some novel information from that perspective, and finally, whether that information is going to make a big change in our clinical practice right now. So we are not focusing too much about a lot of pathophysiological changes which may not have implications now. They may have implications later once those drugs are developed for that or some new tests are developed. We are focusing on clinical practice changing scenarios as to how you will help out. So whether you want to do an extra blood glucose in that perspective, what criteria you want to use in terms of diagnosing mini puberty or around that age group, or when should you think of a permanent hypothyroidism in that regard. So these questions can change our practice from that regards. All of you can go and have a look at our website learning.growsociety.in, which has got a lot of resources related to pediatric endocrinology. We offer courses including fellowship and diploma programs. We have got multiple sessions which occur including the PG lecture series, the journal club and grand rounds. Our publications are there, and you can look at our mobile application which provides realistic point of care guidance for pediatric endocrine disorders. So today we have got 3 major articles. The one is 1 hour value of glucose in OGTT, because we know that OGTT is something which is quite confusing and often the results are not reliable. So they are in fact not even reliable. So every time you do OGTT after a month, your results may be different. Forget about validity, reliability itself is a question. Then we'll talk a bit about mini puberty and the role of imaging, because a lot of patients that come to us at between 6 months to 12 months of age, how do we interpret their gonadotropin levels? How do you interpret their uterine sizes? And then we'll have a talk about congenital hypothyroidism and gland in situ, which is a common scenario. We get an ultrasound showing a gland. What is the likelihood that this patient will require for long, whether we will be able to revert it back or not? And then I'll talk about 4 or 5 new things, particularly technology related, which are really going to change out in that perspective. So we have got new ways in which there are AI models which can guide the management of thyrotoxicosis without even going to the physician. There are tools which can detect acromegaly just by change in voice, which is there. There's a novel PTH, a long-acting PTH, which is now going to be available, and salivary cortisol is going to emerge as a role for adrenal insufficiency. So there are a lot of things in store. We'll start off with Dr. Alappan, who will be talking about an interesting idea which aligns with his study, which is the role of 1 hour oral glucose tolerance test in children. Dr. Alappan. Role of how do we reevaluate somebody who has congenital hypothyroidism on follow-up. So Dr. Nimisha will talk about this study.
I will review the study published in JCM in 2025 by Lusa Pignata et al. On clinical course of congenital hypothyroidism with gland in situ and necessity of L-thyroxine therapy after re-evaluation. It was a retrospective cohort study with they included 77 children which were born in between 1987 to 2018 with gland diagnosed as congenital hypothyroidism with gland in situ. The children with chromosomal abnormalities, thyroid gland agenesis, dysgenesis, and hypoplastic thyroid gland, ectopic thyroid gland, or those having central hypothyroidism or transient forms of hypothyroidism which resolved within 1 year of life were excluded in this study. Their objective was to evaluate the long-term clinical course of such patients and the proportion of patients in which the therapy of LT4 can be discontinued after reassessment. Their follow-up period was interval between first and last visit to hospital, and it should be more than 6 months. It was a study design. They included 77 children in this study, male being 43 and female were 34. Which were diagnosed as congenital hypothyroidism, and gland was confirmed with neck ultrasound or iodine 123 scintigraphy. After 3 years of age, only 55 children were left to follow up. In them, the LT4 was stopped for 4 weeks, and after 4 weeks, thyroid function test along with anti-TBO antibody, thyroglobulin antibodies, neck ultrasound, and iodine 123 scintigraphy was evaluated, and patients were divided on 3 groups based on the thyroid function test, as those having TSH less than 4 were considered as euthyroid, between 4 to 10 as hyperthyrotropinemia, and more than 10 as hypothyroidism. uh, this was the flow chart. The 77 patients were included, 2 were excluded because they were transient hypothyroidism. At the end of 3 years, there were 55 children left. Among them, it was seen after stopping LT4 for 4 weeks that 18 were euthyroid, which is 32.7%. 40% of them were are falling under the group of hyperthyrotropinemia, and 27.3% were under hypothyroid group.
What they're suggesting is that patients who have hyperthyrotropinemia, most of them are going to relapse.
Yes, sir.
So somebody whose TSH is more than 4 to 10, or their protocol was such that 4 to 10 they will treat.
No, sir, they have not treated.
Okay.
More than
So-
10 they have
But most of them would probably progress.
progress.
Yes, out of 14 and 24 are there. So this is
Among within long follow-up, only 49 people, children were there
after suspension at last.
at last follow-ups.
6 patients which was dropped. Was them was euthyroid or
Lost to follow.
Lost to follow.
They will tell in the next slide, I think.
The group was 15 patients were hypothyroid with median age of 6.46 years, and median TSH was 19.
And this TSH is that diagnosis.
This at diagnosis, sir.
First TSH.
First diagnosis.
Okay.
The therapy. No, sir. This was after
Second,
stopping.
reassessment.
At reassessment. The therapy was reintroduced in all of them. On long-term follow-up, the one was lost to follow-up, and the 13 of them was continued on treatment, and one became euthyroid. Uh, the group having hyperthyrotropinemia, the median age was 4.94 with median TSH of 5.55. On further evaluation, the therapy was stopped in 5 patients, and on further follow-up for the long at the end of the study, 2 continued treatment, while 3 there was no need of treatment. And the therapy was continued in 17, and in that also the 6 does not require treatment after long-term follow-up. And in the euthyroid group, which included 18 children, the therapy was stopped in 15, and in them, the two required treatment on long-term follow-up, and the therapy was reintroduced in three of the patient, and on long-term follow-up, only one required treatment.
So what does it mean? That if your TSH is less than 4 or in the normal range, you have around 20% chance of developing hypothyroidism. While if it is in between, you have around 40%. While if it is really more than 10, it is like 90%. So it's just a gradient in that perspective. So what it tells us that even if you are labeling somebody as euthyroid, you should keep on following them up on that regard. So what was the gap after stopping treatment? When did they recheck the thyroid? After
4 weeks.
4 weeks. So it may have been a bit early. So if they had checked after 6 weeks, maybe many people might have been picked up on that. What are you saying?
At the end of the study, the only 49 patients were left, which were, they classified for the easy transient congenital hypothyroidism and into permanent congenital hypothyroidism. Transient one were those which in which the LT4 was stopped for 6 months and they remained euthyroid. The median age of stopping the LT4 was 6.6 years, and median duration they remained euthyroid was also 6 years in their study. On comparing the parameters of permanent congenital hypothyroidism and those having transient, there was no difference between sex, birth weight, or gestational age at birth. However, the neonatal first serum TSH was higher in permanent congenital one compared to transient. And TSH at clinical reevaluation, that is after stopping the therapy at 3 years of age, was also higher in permanent group. And the LT4 dose before last trial of the therapy was also higher in the permanent congenital hypothyroidism group compared to transient.
So what this study basically tells you that if you have a primary hypothyroidism, which is eutopic thyroid, neither ectopic nor dysgenesis, you have a 50% chance of recovery, which is a very, very big number. Did they exclude dysharmonogenesis at all? Because they didn't mention about dysharmonogenesis. So this means they are assumed dysharmonogenesis. So if you have a eutopic thyroid, you have a very high chance of remission. I would not give much importance to 31 versus 53 because you will not, how will you decide? There's an overlap also. So people who had permanent had an initial TSH of 12 also. So you can't use that as a cutoff. Similarly, the dose also somebody was only 0.87, so you can't use. So what it tells us is that if you have anybody who has eutopic thyroid with the congenital hypothyroidism, you should give a trial of discontinuation. Maybe 4 weeks is not good enough. You should have given for 6 weeks. But this is the
I
message.
think that the group which had higher TSH at initially and the therapy, the treatment dose was higher before stopping, was
I know.
usually permanent.
But there is not much discrimination. I don't think there will be a p-value which is significant. If you see there is so much overlap. So 0.87 to 3.64, it doesn't make any sense. 0.5 cents. So what cutoff? I would be more interested if they tell me that if your dose is less than 1, you can stop. But there is nothing like that. Similarly, if they told me that if the TSH is less than 20, then you can stop. That is also not there. So it is just a trend that they have found, but you can't use that clinically. Which means everybody, you should try to stop. Because people who have had much higher value of 150 also, and people who had a LT4 dose which was 2.2 also recovered. So this is something you need to be clear. So which means that probably you should give a trial to everybody, at which we do as part of our protocol.
This is the box and whisker plot showing the same thing. The group,
So if you see there is no difference between and these are all overlaps. LT4 daily dose, neonatal TSH, everything is there. Obviously, TSH after clinical evaluation, you have classified them as such. So the best marker, if you want to know, is the TSH after stopping. And maybe if you had given 6 to 8 weeks, it will be even better.
a few patients of them went into perchlorate discharge test. The total iodine organification defect was found in 2 patients and they remained hypothyroid and continued treatment till the study was being done. And those having partial iodine organification defect have mixed outcome. 1 was hypothyroid, 3 have hyperthyrotropinemia, among which 2 became euthyroid and 1 had developed thyroid autoimmunity, so was continued on treatment, and 3 remained euthyroid. The conclusion of they made from the study was that LT4 therapy is not always permanent in congenital hypothyroidism with gland and C2. 49% of their patients were able to discontinue therapy with normal thyroid function. There was no difference in neonatal TSH, birth weight, gestational age, or sex between transient and permanent congenital hypothyroidism. TSH level was significantly higher in permanent as compared to transient congenital hypothyroidism, and LT4 dose before trial of was higher in permanent congenital hypothyroidism. And some patient may develop hypothyroidism even years after initial euthyroidism. Therefore, there is a need of long-term monitoring. The limitation was it was a retrospective study, single center study. No comment on growth and neurodevelopmental outcome of children was made. They took a lower neonatal screening TSH cutoff. The cutoff was progressively decreased as the year progressed. During the period of 1982 to 2002, the 20 was the cutoff of TSH. And between 2003 to 2015, they took 15 as the cutoff and 15 to 16 as 10, TSH 10, and beyond 16 as 9
So do you think this caused more transient in this case?
Yes, sir.
But to answer that, you need to know how many of them were actually between 9 and 20. Because even more than 150 also you are saying they're transient. So this may be a factor, but may not be a very important factor. Even if they were using 20, many of them will still be transient. So that is very obviously transient means there is some problem there. So they can have TSH anything. I have seen patients with maternal TRAB antibody TSH is more than 150. Somebody with iodine problem, amiodarone, they can have very high levels. But then later on how they behave will be a much better scenario. So what Alappan do you think are the major pointers towards a likelihood that this could be a transient form, or you will be able to take off the dose?
Lower dose requirement, initial the TSH, the initial cutoff TSH lower limit, the gland institute presence of the gland, whether present or not, any maternal history of hypothyroidism, whether present or not.
And the TSH never goes up during follow-up.
Yes.
And the TSH has gone up again on follow-up, then transient becomes very, very less likely. You don't need to give a trial in that case.
So if 9 was taken, so the chances of false positive
Yeah,
things are
but that did not make, because you saw 150 also recovered.
Yes.
So
the strengths of the study was that they took a moderate sample size of 77 children. There was a long-term follow-up study. The clear outcome classification was done into transient and permanent congenital hypothyroidism. The key messages we got from the study is that thyroid function monitoring over the year is essential in children with congenital hypothyroidism with gland and C2. Trial of therapy at 3 years should be done to evaluate the true need of long-term hormone replacement therapy. And after discontinuation, also, a patient should be followed up with thyroid function tests as they may become hypothyroid again. The relapses of moderate hyperthyroidopenia is seen during puberty and pregnancy.
aware about. So we tried to cover all those interesting topics. So all of you can go and have a look at our website, our courses, our public.